Okay, our presentation today, chest wall deformities, concepts we will gain from this chapter, presentation and overview of pectus deformities, which include excavatum and small overview about carinatum, as excavatum is the most common one, diagnostic workup, surgical technique, ravage and NASP procedures, and some potential questions, alternative scenarios, and perils and pitfalls. Inshallah, we'll summarize today. Less than 1 hour will be finished, inshallah. So, a case today is Dr. Ata. Can you read this, please? تفضل يا فندم.
Because I have a common cold, so my voice will be
لا
a
والله
little bit.
جميل.
So
تفضل
we
يا
will
فندم.
start with scenario 1. A 16 years old male with a history of asthma present to his primary care physician with a 2 weeks history of palpitation. He has been otherwise healthy, although he's noticed that he's more fatigued with exercise over the past several months. He denies any tobacco or drug use. His family history is notable for aortic insufficiency in his mother. It tells you that his chest looks funny and that it has been that way his entire life. But he has noticed it more recently. Physical exam reveal a tall, thin male with pectus excavatum deformity and normal cardiopulmonary exam.
I will summarize after Dr. Ata. A 16 teenager, have a history of asthma, past the family history aortic insufficiency, went to the primary care physician as a palpitation and fatigue. His mother informed that his chest looks funny. By physical examination, this patient has a tall and thin and have a pectus excavatum deformity with normal cardiopulmonary exam. So what's the next step of this patient? Unmute and share us, please, your next system. From my side, I think this patient have a pectus excavatum, so we must go for assessment of degree. Anything else?
Yeah, from the history, you can just extract that the patient himself is shy from his body shape because he himself told you that he looks funny. So he don't trust himself anymore. A background withdrawn from any social activity. You have to take this serious when the patient said, I looks funny." Yeah, you have to understand a lot from this announcement. Definitely, this patient had a pectus excavatum, and definitely you will go through a lateral X-ray, CT scan, which is diagnostic for a pectus index. But from this history, you have to take this serious. Not only we will discuss later about what is the indication for surgery.
Anything else after Dr. Ata? Next step for palpitation is EKG and chest X-ray. So we'll start by imaging and EKG. And after that, assess the degree of this pectus. Palpitation 16, okay, needs echo also. Take history and physical examination for this patient before investigation. But the investigation recommended, I will ask again, EKG, chest X-ray, and imaging, maybe MRI. Anybody agree for MRI?
I don't know why.
Dr. Ata disagree. Dr.
I
Samer, sorry.
disagree. I disagree with MRI as initial diagnostic tool. I'm going with palpitation, maybe with after echo and EKG, thyroid function test as well, and also to exclude any like kinds of fake chromocytoma, some like metanephrines or something like that, hormone related things.
Yeah, but Dr. Samer, I can see the pectus excavatum funnel shaped. I think it is a severe degree causing palpitation itself. What's your opinion here?
No, it depends on the severity, how much it's like the breast, the chest wall.
Recommend calculation of Hiller index by CT or MRI. From MRI, but CT is sufficient. Pulmonary function, EKG, and echocardiography. But rationale for this, I think, for this investigation, for preoperative assessment, not for assessment of palpitation. So calculation of Hiller index CT.
Yeah, Dr. Hammer, but ECG and echo is not only as a pre-op step. No, it's like to assess the degree because there is a lot of case report with old age, above 50s, known case of right side heart failure after correction of pectus excavatum. So you have to assess the degree. Is there any mitral regurgitation or mitral insufficiency or right side heart failure corrected by correction of the pectus excavatum? So I think it's not only from a preoperative point of view as a preparation, as it is to assess the cardiopulmonary function status that it's seldom indication for correction.
But one of the indication for correction is right ventricle dysfunction or mitral valve prolapse due to compression of this sternum.
That's why you do echo, because you have to assess if there is any cardiac insufficiency or cardiac problem from the pectus excavatum itself.
Okay, so as regard of Hiller index, anybody can illustrate to us this or summarize to us? How can we get it? Anybody can
Yeah,
help us?
unfortunately, the transverse diameter of the chest with the narrowest point of the chest from the longitudinal and transverse diameter, it's not always like this diagram because there is a lot of asymmetrical deformity in the real people after 16, especially after puberty. So it's really hard to get the exact narrowest point, but I used to get multiple narrowest points with a multiple Hiller index and take, let's say, 3 Hiller index of the same patient and then take the average.
Go for average, yes. Okay, Hiller index is a measure of pectus severity is obtained by dividing the transverse thoracic diameter by the anterior-posterior distance between the posterior sternum and the anterior vertebral body. Hiller index less than 2.5 is considered normal. Value more than 3.1 are considered severe. I think there is more details about that, but let's remember 3.1.
3.1 and 3.2. I think this is just to guide the surgeon for the indication for surgery. But let's assume that you have a 2.7 patient and he really want to do it. If you say for the patient, okay, you are not 3.2. Who put those numbers? So there is a lot of, and the other patient with a 3.2 or 3.3, and he don't complain, and he just was seeking for your opinion. You don't have any, let's say, cosmetic problem or any problem with his body shape. Do you have to do it? So I think this number just to classify the degree, okay, for us as a surgeon, okay, this is a severe pectus, no, a mild degree of pectus, more than the indication for surgery itself.
Okay, I read today in, I think Sugar Becker, this name of a book, Sugar Becker, right?
He's a big surgeon, yeah.
Okay, so I will just...
The book, Dr. Aimer, is Adult Chest Surgery by David Sugar Becker et al. And now we have the second edition of this wonderful book.
Fantastic, sir.
So let Dr. Amr let us do something here. So I think it is a reasonable purpose for doing this surgery, not just the Hiller index per se, because when we are dealing with like child age above 12 years old, when they come with a mild deformity, and if you need to correct that earlier, because this Hiller index will be going up with age. This is number one. Number two, from the cosmetic wise as well, I guess maybe early correction will be better. A third thing, most of those deformities came to my clinic sometimes associated with other like scoliosis. It's like combined as well. So you can have pectus excavatum or carinatum associated with scoliosis. So sometimes we are just doing hybrid procedure with the spine surgeon as well. So it's we cannot say absolute number for this Hiller index, and it varies also from population. So if you have a patient from Yemen, and they are thin, it's different than those with like obese people sometimes. So it needs sometimes to be justified.
Exactly. Yeah, I agree strongly that the number mean nothing. The numbers mean nothing for those patients.
Okay.
But for the exam, Dr. Amel, stick to 3.2.
That's it. Okay, criteria of surgical correction of pectus excavatum. This is a table in Sugar Becker. 2 or more than of the following indicated for surgical repair: progressive or symptomatic pectus deformity, restrictive disease on pulmonary function test, chest CT with cardiac compression or atelectasis, Hiller index more than 3.25, cardiac abnormalities found on echocardiogram like mitral valve prolapse, decreased diastolic filling and bundle branch block, also recurrence, 2 or more. Okay.
And I read somewhere in your presentation that there is hereditary, I think, or family history. We don't know, but we face it a lot to have 2 brothers. And lately, last week, we operated one with the NAS procedure. His brother stand beside him. And I look at him. I said, "Okay, do you have the same?" And he exposed the chest by a funny way, and he said yes. And my cousin also. So we saw it in one family before, not only the last week. I think there is it's not a suggestion, but there is a strong evidence that for family history for
Okay,
that.
but rare, Dr. Ata.
Yeah, it's very rare. It's still, I personally face it like 3 to 4 times.
Yes, yeah. Okay, so another test is pulmonary function testing, including spirometry. I think we'll go for restrictive pulmonary disease. EKG will show some changes like asymptomatic in some patients due to displacement of the heart by deformity. Frequent changes noted include S1, S3, or S1Q3, and negative B waves in V1 and C, RSR pattern in V1. Notably, these changes frequently disappear postoperatively with correction of cardiac malpositioning.
Dr. Amir, excuse me.
Yes, sir.
It is pronounced as RSR dash. Okay, remember exactly what are the causes of it, but it's like having a small s followed by a repetition of the R. I can check for you what's the meaning, but yeah, it's an abnormality in ECG, and they call it RSR dash pattern. Okay.
Yes, sir. Thank you, Dr. Hussein. That's it. RSR dash pattern in V1. We'll summarize A and B and C. A, S1, S3, or S1Q3, negative B wave in V1, RSR dash pattern in V1. And these changes will be disappeared postoperatively after correction of cardiac malpositioning. Echocardiography, I think, will show, as you know, transthoracic and transesophageal. Both of them will show mitral valve prolapse, decreased diastolic filling. We'll move on for index scenario or additional information for this patient. MRI of the chest for the patient is performed and revealed Hiller index 3.2 and BFT is normal at rest. EKG show frequent premature atrial contractions with RSR dash pattern in V1. Given the patient's history of palpitation, Holter monitor is ordered and the event log notes frequent premature atrial contractions and premature ventricular contractions with several runs of SVT. Echocardiography demonstrates right ventricle compression with mildly decreased function, normal LVAF, and no valvular abnormalities. What's your next step? I will go for surgery. What's your opinion? تفضل دكتور سامر.
Okay, because there's just this is high risk, interrupt to have a cardiac events, So I guess I should involve cardiologists in the management as well. So before that, we should like doing a little bit of control of heartbeats before going to the surgery. Any other pathology, combined pathology, away from the deformity compression. But if there is any like cardiac pathology, I know the age. It's like around teenage or however, but we should exclude any other cardiac event at the same time. So the cardiology first should do evaluation, controlling heartbeats as possible as I can, and then also discussing with anesthesia because there is a high risk of cardiac events interop, especially if you're doing a procedure and putting a bar, and you should take precaution even interop, and this is very high risk, surgery.
Okay, Dr. Samer, I got it. You recommend to this patient seen by cardiologist to declare any other pathology and emphasize that there is a high risk patient, correct sir?
Sure, absolutely.
Okay, anything else?
I think the most important, Dr. Amr, in this scenario that you mentioned, there is no valvular abnormality. This will define my approach to this patient. If there is no valvular abnormalities, that means I don't have to go through the chest or through the sternum. My option to counsel this patient, if we are seeking for correction after cardiology clearance, like Dr. Samer said, open my counseling to the patient through an aspar or a rabbit. Preferably, of course, it will be an aspar. Otherwise, if you have any valvular abnormality, the approach to this patient will be changed, of course.
Okay, but I think there is a direct relation between the severity of the by Hiller index severity of the pectus and these cardiac changes. But it's okay. Yeah, in preoperative assessment, it's okay to contact with multidisciplinary team. After that, we will decide for surgery. Was the surgery indicated for such patient? Happy to listen from all of my colleagues and professors. This interactive discussion.
Absolutely, it's indicated in this guy.
Which procedure, sir?
Which kind of procedure?
Yeah.
Of course, because before we had determined the surgery, Dr. Amr, it's always nice to look at the CT scan for the symmetricality of the disease itself, for the pronunciation of the costal cartilage itself, of the lower costal cartilage. We read here that the patient no valvular abnormality, so definitely we don't have to open the sternum. We can offer him NAS procedure, but depend on the severity and the location, either with 1 bar or 2 bar. One of the favorite operation, invasive one, is a NAS, of course, for this patient.
Okay, Dr. Ata, let's move for treatment and management. Due to worsening of pectus deformities during the axial growth spurt period, patients often present for operative evaluation currently. Careful surgical planning must involve discussion of optimal timing due to potential for recurrence if the axial growth spurt has not completed at the time of the repair. This patient 16, what is the proper time to do this procedure?
Okay, there is a lot of debate here. Can I just say my during the BTS guideline now, before the age of puberty, some authors defend that or against that, like you said, because there is axial growth still. But the others, they said, like Dr. Samer also said, it's always combined with some sort of scoliosis. Early repair is easier. Early repair is better for the patient, better for the personality of the patient. Just imagine that this kid, he's suffering from all his colleague and body shape and withdrawn from all those socials. So in the age school, I would counsel the patient to do it before any even, because in Arab world here, as we know, that the puberty age is earlier than Europe or US. So as early as possible, before asymmetry happen. If you see a patient here at 16, you will look at the deformed chest with the right side or left side, really deformed costal cartilage with really asymmetrical deformity. Because some surgeons say to him, okay, go and wait to 16 or wait to 18, whatever.
Mm-hmm.
So just to wait for the axial growth, I'm not with that.
Yes.
I think this age is suitable to go for it. However, based on my experience in this kind of procedure, we can do up to, I guess, like 20 years old or maybe 22. I can do. I exposed to one resident doctor. He's a radiologist in Canada. He was like around maybe 25, and he insisted to do that, because it's a deformity. I mean, just shape. And we did that. Even he's almost like close to maybe 25, 26-year-old. We did that. But it's preferable, of course, before growth plates closed, 19, 18, up to 19, 18 maybe. But if somebody coming to me like within early 20, I can do it also.
Dr. Samer, Dr. Ata, the proper timing for what? To prevent recurrence or to make correction after NAS procedure like that? What's the aim? What's the aim of proper age?
So the aim of this procedure just to prevent further progression of the deformity. It's not really like you reverse it like to the normal shape. No, it's just to prevent further progression. And you think about the removal of bar, like after you cannot like put the bar more than 3 years, or I think 2 years. It's the optimum time to get the NAS bar away or out. It's 2 years because it's painful. It is very painful. I mean, to keep it.
So, Dr. Tamer, a direct question to you. If you have a patient in your clinic, 14 years old, and he really suffers from his body shape, and the Hiller index is not that much, let's say there is no compression on the lung or the heart, he just wants to do it 3.2 symmetrical shape, you will counsel him not to do it till he reach 18?
No, I will do it.
This is what we agree on that.
No. Yeah, but maybe you misunderstand me. So no, I mean, if like what the optimum age to do? I can.
Okay.
Yes.
Yeah. I got your point. So the optimum age, I think even early than 6, it's better to do it earliest.
Okay.
I think your question not answered.
Yes.
The optimum age.
The
optimum age to avoid recurrence or what? And does it matter your approach as a NOS procedure or a ravage technique? Because with NOS procedure, the bar will continue for 2 years or more. So it is a process of management. If the patient is 16, the correction will continue for 18. But if you ravage at 16, the process of correction will be finished with surgery, or if you insert cystic part will be removed after 6 months. So the process will finish. So if there is still growing cartilage, there is possibility of recurrence.
Yes, sir.
So
Yes.
the question for optimum timing, is it to avoid recurrence, and does it matter your approach will be minimal invasive NAS procedure or a ravage technique?
Yes, please.
I think that we need to tailor the approach and age according to the patient type of deformity he had and the experience of the center we are in. If it's a general rule or guidelines, so it is preferred at or before puberty. Most of the center use it from 12 to 18. Some experienced center like Marmara University, Dr. Mustafa Yüksel, I attend with him. Sometimes he do more than, as Dr. Sami said, 25, 30, but this is not the general rule. And sometimes we go less than 12 in some cases, like patients who's having a severe pectus, excavatum with scoliosis, and they needed to have a correction for the scoliosis. But if they correct the scoliosis, the heart will be compressed between the corrected spine and the pectus. So we have to alleviate the symptoms. So as early as 8, 9 years of age, we can do the procedure. It's a matter of weighting the risk benefit of having a recurrence if we leave the bar for 2 years and then remove it, or to have an early operation. This if we are talking about the NAS procedure. About the ravage, the fear is that the patient continue growth and the cartilages stop growing. So in this case, you might have something which is known as an acquired Jones syndrome, where there is no cartilage and the lung keep growing. And this leads to asphyxiating osteoarthropathy, or known as an acquired Jones syndrome. So if this is an answer for an exam, so we stick to the guidelines just before puberty. If we are talking about a real life situation, then we have to tailor our approach according to patient characteristics.
Thank you, Dr. Hassim.
Yes, guideline before puberty is just go for correction.
Extreme cases may make confusion to the juniors. Let's speak about a straightforward case as indication according to guideline. Forget those who come late after 20 and those who come early before 10 or 12. During the straightforward case presented just before puberty or at the time of puberty, age of 20, age of 14. What is the ideal time if you are going to NOS procedure or you are going to ravage procedure? In simple words, for the juniors.
The ideal answer is just before the puberty. It is all the guidelines. Once the patient dropped in your clinic, he wants a solution. They seek for a medical advice. They want a solution, either the parent or the kids himself. So I'm willing to do it as early as the patient dropped in your clinic, even for a cosmetic reason. Forget about the recurrence. If you attack early, you will prevent asymmetrical growth of the body shape. You will do a patient a favor. Once the patient dropped in your clinic, offer him a NAS bar, especially if he don't have any structural heart disease. I would go with the NAS bar whenever the patient in my clinic, 12, 13, 14, because if I think about the recurrence and they said, no, just wait, you will fall growth, and he have a severe asymmetrical body shape, it will not be an easy correction after that.
Okay, both procedures, one of them is best pre-puberty, as I understand.
So, Dr. Amir, I have something to add here. Most of the people here in our Arab countries, they are getting attraction to this deformity around 12 to 14 years old. When his kid, son became within 12 to 14 years old, they are starting seeking medical advice. Okay, I got deformity or funny shaped chest, and go and do correction. So when you do the correction around 14 or 16, and you put a bar for about 2 years, okay, and you get it out after 2 years, and you will give them instructions to do the exercise. You have a exercise also to continue, and exercise to continue keeping the chest in a good shape. So I guess you reach when you start the surgery 16, so you reach around 18 or 19, in which the growth plate will close or will stop growing. So this is I think the ideal, which is written in books or in exams. But however, as all my colleagues here now they mention, as most of you, as also in our practice clinic, there is a lot of difference, individualized based. So Some people are asking for cosmetics. Some people, they are scaring of, compression of the heart. Some people, so you cannot have like absolute indication. But generally speaking, yes, of course, before the growth plate will close.
Okay, safe. Okay, as regard of principles of each procedure, Ravage is the oldest one, 1949. Ideal surgical repair for pectus consists of bilateral subpericondrial resection of all deformed costal cartilages, typically from cartilage 3 through 7, in addition to an anterior wedge-shaped osteotomy to elevate the sternum, which is supported by a strut for 6 months to 1 year, while pericardium heals and ossifies. The principles of Ravage like that. As regard of NAS procedure, first described 1988, involve insertion of convex steel bar underneath the sternum and takes advantage of the flexibility of the anterior chest wall. Performed via thoracoscopic minimally invasive approach, it has gained popularity in recent years, particularly among patients. The next question is, what's the preoperative preparation for this patient? Preoperative consideration.
Okay, so two main things here. Number one, cardiology, as well as anesthesia for pain management.
Okay. If we select NAS procedure, any concern about bar selection or some precautions like that? Before OR, any consideration for this patient put in mind? So preoperative consideration, preoperative evaluation should include careful history and if any family or patient history of allergy to nickel or metal is noted, allergy testing should be performed. In the event of allergy, titanium bars may be used. Okay, good point. However, these are significantly more expensive and should be reserved for cases of necessity. Another thing, bar sizing can be determined preoperatively using cross-sectional imaging by measuring mid-axillary to mid-axillary distance across the deepest segment of pectus depression. The optimal bar is 1 inch shorter than the distance from right to left mid-axillary line. Preoperative discussion about pain control is crucial to recovery and may include thoracic epidural or BCA. I think it is a new point. Allergy to nickel.
I like
Right.
this point of view of bar sizing. I hope that you just, after the presentation, just share it in our group.
Okay, we'll move on for operative steps. No need to go for operative details. NAS and Ravage. After that, alternative scenario, 17-year-old may present another alternative scenario, present for surgical repair of pectus carinatum defect. He's otherwise healthy. You have discussed the surgical options with the patient and his family. A Ravage approach is chosen for carinatum. Okay, how can this procedure be modified to treat pectus carinatum defects? The question for all.
Well, before this answer, because I think I read it bracelet now. I doubt that the Ravage is a surgical choice now for a carinatum.
Totally agree. Nobody using surgery for carinatum.
Yeah, it's Ravage is not anymore for a carinatum because you have a non-invasive procedure and it's really good with a good result. As I read about it, I never used it. But if somebody here have any experience with that, just share with us.
Sometimes with asymmetrical carinata, more prominent on one side with rotation of the sternum, you need to do some sort of Ravage.
Okay. So the osteotomy, Dr. Amr, I think with the Ravage for a carinatum, the osteotomy side from anterior to excavatum, but you have to do it posterior osteotomy for carinatum. More than anterior osteotomy. I think this is the question.
Okay, Dr. Ata. I think Dr. Hussein, any additives, Dr. Hussein Khayat?
No, Dr. Amr, we just recently start to use the pectus billet for those kinds of pectus carinatum, trying to avoid the surgery. But most of the time we try to use it in a younger age. I think this patient is 70 years of age. We try to use it just before the age that we need to do Ravage if we decide to do it. And we still need to wait for the result because the patient needs to wear the billet for like 1 year, and maybe the result is not apparent until 6 months from wearing it, because it depends much upon how the patient can tolerate having this billet and how many hours he's wearing it. Some patients do not like to wear it all the time or just take it time. So I think we are just in early in experience. We see some good results with expert centers like Mustafa Yüksel, but in here Not yet.
Okay, see.
The patient compliance is the most important point in this bracelet or these devices. I read about it that sometimes you have to tell the patient if the patient will not comply to wear it at least 16 hours per day. It's not indicated for that patient.
Totally agree, Fam. Totally agree.
I have a lot of patients of carinatum. Like every week, I have maybe 2 patients. All of those patients should be like we're using bracing, modified bracing, as you mentioned. In the first month, may never be like released just for bathing. You know, the next month, yes, just like 8 hours releasing, and that there is like a sequence you should the patients like following. But most of the carinatum, I didn't see any surgical procedure for carinatum, just bracing.
So that's great, Dr. Samer. Your center with real experience with that. What about in the real life? The patient compliance is really good. Is there
No, they are very bad.
kind?
No, they are very bad. They are poor compliance. They are not following the instructions, of course.
Yeah, that means that it is painful or discomfort because if you have a lot of patients
Yes,
not compliant, that it will be like to explain to the patient what is the expectation. So I think it's painful, or at least it's a little bit discomfort for the patient just
No,
not to wear it, right?
it depends how much the chest wall prominent. You know, I saw some chest deformity like a bird beak. You know, bird beak.
Yeah,
Yes. Yes, I prescribe them Brufen, like painkillers. Some of educated people, you know, they are following instructions. Some of people, no, they are poor compliance. No, it depends.
So for the rest of us, if we don't have an experience on those bracelets because we don't have it, let's say, how can I judge that this patient is fit for those devices, or just to offer him a ravage? What kind of degree, what kind of asymmetrical, what kind of carinatum? Just to refer this patient to one of my colleagues who have those bracelets, or okay, I will say no, you are not fit. Let's offer you a ravage.
No, I don't have experience with the ravage for those carinatum deformities. However, we're doing modified or customized bracing from the medical supplies companies, you know. So they are measuring the circumference, and they are putting it like in a tight way. And they are putting, you know, something in precaution on the skin to avoid any necrosis on the skin as well. And we are following those patients like every month.
So even if we have like our colleague here, if we have asymmetrical carinatum, those devices tailored for those patients.
Absolutely.
Okay, interesting.
Number one, I have seen regarding this carinatum, I have seen one of the team of Dr. Mustafa Oxel from Turkey doing nose procedure, not nose procedure, using the nose part submuscular from outside, fix it to the ribs to reduce and correct pectus carinatum. I don't remember the name, but we did this procedure once. I have seen it once from the team of Dr. Mustafa.
Abraham's approach, sir. Abraham's procedure.
I don't remember the name. This one issue, if anybody have a comment. Another point, rapidly, if the patient of pectus is associated with scoliosis, how much is the angle that you can correct pectus directly, or you have to wait to combine surgery with the neurosurgery, which one should be done first, correction of the spine first, or correction of the pectus again. The third point is if there is associated congenital anomaly. If it is congenital or valvular, not yet indicated for surgery, what will be the approach?
One by one. The first one, please.
The correction of pectus surgically with minimal invasive through insertion of, can you imagine, Amir, if you insert the same bar of nose procedure, but subcutaneously outside the chest, not in front of the sternum. It will pass in front of the sternum, then reduce the protrusion, and then the bar is fixed to the ribs with the stainless steel wires.
Good point. Okay.
This approach, allow me. This approach is Abraham's approach, as exactly as you described. You just put it subcutaneously or submuscular on the chest wall. It is a very easy procedure, and you don't need to put even a scope inside. But the problem is 2 points. The first point, you need that the patient is not that thin, because if he's thin and don't have a good submuscular layer, the bar will appear from underneath his skin. The second point, you need to have like in the brace, you need to measure how much pressure you need to push down the bar so that the patient is not complaining from severe pain. And you have to, it's not fixed with a stainless steel wire exactly, but it's wire with something like clips so it stay at its place. It's a tricky one, but once you have the equipments, you can do it. As I said, it's not technically difficult. Only you have to have a good patient who's having a good submuscular layer and can tolerate the pressure from this outside bar.
Okay, thank you.
So, Khayyat, why are you doing this complex procedure and doing instead of that doing the bracing?
Exactly. Nowadays, most of the surgeons prefer to do the aspiration for non-surgical option, as you said about carinatum, instead of doing this Abrahams. But sometimes if the patient is, as you all mentioned, that the patient compliance is very poor for this, so Abrahams could institute a good option, and it's as I said, it's technically very easy.
It's called, I think, Abrastine, maybe Abrastine approach. How?
I will recheck it.
Abrastine, yes. Thank you, Dr. Khiyat.
So at least the patient should have a chance with Abras. Before surgery, the patient should have a chance, some sort of Abras or something non-interventional.
It is much wise to do this, I think, to allow him to have a brace for like at least 6 months if he's not coming in a late age, and this might improve even the technicality of the operation.
Okay. The second point, if there is associated scoliosis with pectus excavatum. Scoliosis with pectus. How much degree of scoliosis that will require correction, and which approach will be first, the spinal surgery or the pectus surgery?
Actually, I did not see something in the literature talking about this particular combination, but we have very few patients who's having this combined approach. Most of the time, we consult the spine surgeon in the MDT and ask if he needs to operate the patient now or he have to wait for some time. And if he will operate the patient, to have his enough space for the cardiac. On the CT, the cardiac shadow seems it's okay to have the correction, or it will add more compression to the heart if we just correct the spine now, and they have to correct the pectus first. Samir have some experience on those patients with scoliosis?
Sorry, no, I don't have, but I don't have experience. I didn't have really patient with both. However, I guess this will be like discussed with the spine surgeon. It depends on the severity of scoliosis, but maybe they're doing it at the same time. They can do it at the same time with very good pain control management.
When we discuss a surgical repair for a severe scoliosis, you are discussing a NAS or ravage, because it's really big difference between both. If you went through a NAS, the spine surgeon, they have to do it before you, because if you did a NAS and they come to repair the spine, there is a lot of resistance. They cannot just repair because the chest wall is just tight in place and the ribs is just tight in place. But in case of severe scoliosis, ravage will be a good choice if you are going both together, because we have a case like that before with a severe pectus excavatum and severe degree of scoliosis. So we offer a patient both procedure in the same session of OR with a good result. But in NASPAR, you cannot just do like that. You cannot repair before the spine just to give a heart space, because the spine cannot just repair everything while your NASPAR is there.
Is there any study that follow progress or the fate of mild degree of scoliosis after correction of pectus?
I don't went through that, but I heard some colleagues also say it in severe scoliosis, they expect the heart will be more compressed. Do you believe that the heart will be compressed with those patients to the degree it will be a severe or a life-threatening? Because all the patients of pectus, we saw a severe pectus excavatum cases, all the heart checked to the left with a mild degree of cardiac symptoms. So how we can judge that the heart will be compressed in the spine if we correct the spine before the sternum? I prefer that if we have a scoliosis to repair it before, if we plan for a patient for a NAS, at least a spine correction before NAS procedure, just to look at the final shape before any part, it will be a good idea.
Good point. Thank you. The third point, Any comment for this point? The third point is there is associated cardiac anomaly. Suppose ASCD or valvular lesion, but not yet indicated.
If you have a valvular lesion or any structural heart disease, I think this is a straightforward indication for Ravage to do both in the same procedure.
So suppose this valvular lesion, because some valvular lesion has indication, and the patient can progress, can wait for years or can tolerate for years. So can we do NOS procedure and after removal?
In the cases of mild regurgitation or mild prolapse or right side heart dysfunction, there is a lot of case report that after correction of the pectus excavatum by NOS, it's repaired spontaneously because it was from the compression of the anatomy of the heart.
Regardless this deformity, suppose there is ASCD, atrial septal defect, or there is Marfan patient. Some of these cases are Marfan, and they have, for example, moderate aortic regurg. Yes, this will need surgery now, maybe not yet indicated, but in the future he will need surgery. So can we do NAS procedure and after removal, following the patient when indicated, after removal of the bar, we can do median sternotomy?
This is the beauty of NAS. If you insert a NAS and you remove it, he can go for any sternotomy. Normally.
Okay. Another third, an interesting point, and I read that with NOS procedure in place, if such patient develop catastrophic cardiac arrest and you apply DC shock, this shock will not be effective because the current will pass through the bar. And some advice, of course, there is no experience now, no much cases to gain guidelines, but some advice to apply the shock anteroposterior, not with the usual place for DC.
It's good to know, but I hope I will not operate on a patient with arrest.
But I read it as a case report.
You are going by on the C, doctor. يعني اصلا يعني كل اللي بيجوا اصلا انا شفتهم كلهم يعني التين ايج كلهم هذول اللي بيجوا.
Yeah, exactly. So we hope that our patients will not be arrested. Alhamdulillah.
Okay, mitral prolapse بكون عندهم اسلام insufficiency بس ما بكون عندهم severe structural heart disease. إذا عندهم severe structural heart disease ولا ASD ولا PSD.
It was a case report. He developed the arrest.
Maybe yes, of course, maybe.
Not during the procedure.
Yeah, it's really good to know.
Yes, but when you apply the DC in the usual places, in the usual site of application, effective. And the explanation that the current passes through the bar, the electricity passes through the bar, not through the heart. It wasn't effective. And some advice to apply it anteroposteriorly from one blade anterior and one blade posterior. It was just, I read this in a case report about 10 years ago. Thank you so much.
As regard of CPR in such patient also will be challenging.
من نادي الدفاع المدني.
By the way, the angel of death will not see the passport or... Okay, very good point from Dr. Hamed. What are the most common complications after repair for pectus deformities? I will start by pneumothorax, infection, anything else?
I think pneumothorax and atrial fibrillation, some AFib.
AF.
And pain, of course. The most challenging things, pain, yes.
Mm-hmm.
Pain will lead to the AFib.
If you are talking about the NOS procedure, you also can add the allergy to the bar at the nacal or other stuff. If you are talking about the open surgical technique, the risk of infection and of course pain for all will be a devastating complication.
Okay, thank you, Doctor. Okay, prior to introduction of NOS bar stabilizer, bar migration was not uncommon. Reoperation following NOS procedure for bar correction was required approximately 4% of the time. Following the introduction of bar stabilizer, this complication has nearly disappeared. Most common complication in the current era are pneumothorax, which occurs up to two-thirds of the time, but rarely require intervention. Wound infection 1%, hemothorax 0.5% are also recognized complications. Our perils and pitfalls, pectus excavatum and carinatum are the most common chest wall deformities, with pectus excavatum representing most cases presenting for surgical repair, more common in males and frequently associated with Marfan syndrome, and connective tissue disorders. Hallux index transverse thoracic diameter divided by AP distance from posterior sternum to anterior vertebral body more than 3.1 considered to be severe. Both of ravage and NAS procedures, both well tolerated with low post-operative complications rates. Thank you very much.
There is now a study coming from Korea and starting to be practiced from the medical supplies companies for pectus excavatum. They're using now vac bell over the chest. So I went through this study in details. It's just one study coming from, I think, Korea or Taiwan. I don't know. I'm not sure. But this is not long-term outcome mentioned about. But now the standard of care, of course, it is a NAS procedure. Just to mention that for you.
Okay, thank you, sir.
Okay.
Can you send this as a group, Dr. Samer, the paper itself, or is still processing study?
No, it's already published. So I think from Taiwan, but there is no long-term like follow-up, so we can't. But now here we are from Jordan, so they're starting the medical supplies companies to announce that, doing awareness about that, and even some people they're starting practicing the vac bell instead of doing of NAS because it's expensive procedure, costly, and some of them they are traveling to Turkey to Uxol. However, just to bring your attention that they're starting having the vacuum bill, but no study, and it's not standard of care.
It has been used for a long time also, but it should be also a trial early before the age for correction before the proper age for correction at younger age, provided that there is no congenital cardiac anomalies. Another question we can complete on the group. You stuck to the measurements, to the NAS technique of NAS measurement of the bar, the technique of NAS, or you use the shorter technique of Sassagard of Denmark. Which one you are following and in advantage? Shorter bar measurement.
For measurement, you mean the bar measurement?
Yeah.
So I use the meter. I use the meter from mid-axillary to mid-axillary.
No, I mean the technique. Most surgeons use the technique of or the original measurements of NAS. But Sassagard in Denmark uses shorter bar. They claim that the measurements used by NAS causes some sort of chest compression.
I don't go through that. However, when you bend it, I think this is you can subtract this distance about 1 inch, as they mentioned. So I don't read about the short bars.
We most of the time use the original technique from midline to midline, but as instructed by mid-axillary. But I was instructed by Dr. Mustafa Yüksel more recently that he used the shorter technique.
Because he was trained by Sassagard.
Yes, I think. Yes.
So he followed the same school.
So Dr. Hussain, what's the aim? What's the goal of this short? Can you mention that for us? No?
It like to take it from like anterior axillary to anterior axillary and try to put the stabilizer as much to the midline as you can, just at the entry point of the bar to the chest wall.
I see.
So
parasternal.
Yes, he tried to decrease the migration and to decrease maybe, as you said, the compression on the chest wall. More or less, it's so far it goes okay for us to use this technique, and the results is okay. Because sometimes if you have the bar, it's extended to the mid-axillary. When you bend it, it's not bending 100%. So you have a space between the bar and the chest wall, and the patient's not very comfortable with this.
Unfortunately, and they cannot even bend the edges because it will not fit in the stabilizer.
Exactly.
Yeah.
This idea was introduced by.
So short bar mean short bar. Yeah, you mean that if I let's say short bar, that means shorter bar, right?
Shorter bar, yeah.
Okay.
Because if from Denmark, the spelling of the name will be difficult. But if I found it, I got his publication on the WhatsApp group.
So, Dr. Hussain, the stabilizers should be fixed like subpectoral, like parasternal?
At the entry, if you put your bar, you try to get the exit point of the bar just at the most curved point on the left side, for example. So at that point, if you put the stabilizer very near to this entry point, the migration will be much less. This is the theory.
I got it. Okay.
I can put some
of the chest would be less of
X-rays of our recent patients on the group, if you would like, to show you the old patient and the new patient and the sizing.
Okay.
Yes, sure دكتور حسين.
Good to know.
Okay.
يعني أنا الأمانة يعني لا أستطيع أن أعبر عن مدى امتناني بجروب اليوم. جزاكم الله خيرا. إن شاء الله I hope إن حضراتكم يعني إيه، أنا عارف وقتكم وعارف الضغوط، بس إن شاء الله نحاول نخليه فيكسد زوم ميتنج في الأسبوع. يعني إن شاء الله لو
واضح إنه كل الجروب ما بيتابع كأس العالم السنة 19.
أيوة بالظبط كده. نتشرف دايما بوجود حضراتكم.
فرصة سعيدة للجميع.
واحنا السايد توك هو الاهم بقى هو اهم كتير طبعا من اللي مكتوب. بناخد الباك جراوند الاول، كل الزملاء بيقراوا التشابتر حاجه كاكاديميك ستادي يعني، وبعد كده السايد توك والاكسبيرينسز هي اللي بتخلي الموضوع شيق وجميل. ارجو من حضراتكم ما تحرموناش من وجودكم في المرات الجايه. سبحانك اللهم وبحمدك، اشهد ان لا اله الا انت، نستغفرك ونتوب